everybody. I'm Julie DiLiberti. I'm a professor of humanities at the College of DuPage, and I do work in global education. We thought it would be nice to have some real-time information from some experts at the college who can talk to us about some of the concerns we have about this global pandemic. I'm with Professor of Biology, Kathleen Finan, who is an MD, and I'm with Dilyss Gallyot, Professor of Nursing, Interim Dean. Dilyss is an RN. She's a certified critical care nurse. Is that correct, Dilyss? She's got a master's in nursing as well as an MBA in nursing. So I think we're in some good company. And I'm going to just start off with some of the basics and then let you two take it from there with a couple interruptions of my questions. So I guess I want to set the basics, the ground rules, and wondering, should we still be masking? Should we still be washing our hands? And what are the other basic things that we can do and that people are doing sort of globally to keep this virus maybe at bay, if that's the right term.
Mm-hmm. I think the foundation recommendations of wash your hands, limit the number of people that you come in contact with, and now we are also saying wear masks when you're out in public and coming into contact with people at a near distance. I think those are the foundation of how we are going to get beyond the situation where we have too high of a risk of spreading this virus. So it's still, and it will continue to be essential that we stick with the recommendations as far as hand washing. That we do use masks when we're out in public. I think we're going to see a lot of creativity and innovation in terms of mask design, fashion, mask fashion. We're going to see quite a lot, but we're going to be wearing these for a long time. We have to realize that this is, you can call it the new normal if you want, but things are going to look different, and we have to accept that. We have to accept that washing your hands frequently is what we do now and what we will keep doing. That wearing masks when we're in public and coming into close contact with other people, this is what we do now. And we will keep doing this. Trying to timing our trips, reducing the exposures that we have so we're not going to the grocery store every day now. We're going to save it up. We're going to make a plan and limit the amount of time that we spend in shopping situations, other situations where, again, we're going to be coming into contact with people. So we have to think about the distance. We have to think about the protection. But yet there's also things that we can relax a little bit. There is no need for us to wash off our cans and boxes after we go to the grocery store. We don't have to do anything special about washing our clothes. Normal household cleaners will get rid of this virus. It's quite susceptible to laundry detergent, soap and water. So these are effective. These are effective measures that we're taking.
Okay. Professor Gallyot, what would you like to add to?
In addition to wearing your masks and hand washing, touching your face, people have, they don't realize how much they're touching their face. And if you wash your hands and then touch other surfaces and then touch your face inadvertently, those are ways that this virus can be spread. Wearing a mask keeps people safe from you and you safe from other people. That is going to be key as we're moving forward. The social distancing, we are now going to see that anybody who is used to standing closer to people, we're going to be aware of each other's space and how far people need to really stay away from us. That there's a lot of evidence that says the further that you stand from somebody, the less that can be spread. And when you put a mask on top of that, we can really get control over some of this. But part of the issue is, what do we do with people who aren't used to being separated by at least 6 feet? It seems abnormal. And as as Professor Finan said, there's many ways that we could actually control this. The way that we clean things, the way that we wipe things off, those are just things to think about. The virus will live on a surface for up to 72 hours. So if something is left for several days, you can wipe it off, but understand that it's probably about 72 hours or so for the virus itself to die on some of the harder surfaces. On a person, it's longer than that. Obviously, it's got a host, but I think that, we need to think about that. See, it's really an unconscious kind of thing people need to do.
But the virus lasting 72 hours, although it's not the full virus for that 72 hours, right? It gets increasingly less strong as we go, as it goes, yeah. So let me ask you both, because we've talked about the masking and the hand washing, and you've talked about the masking, but that's enough, right? What are your thoughts on social distancing? Can we let up? Can we not let up?
Right now is not the time to let up. We're seeing that the dire predictions about how many people were going to get the virus and how overwhelmed the Illinois hospitals were going to be and how many people were going to die. We're seeing these dire predictions are thankfully not coming to pass right now. Hopefully they will not. But it's because of what we are doing. And I think that it is effective. We have bent the curve by which it's very simply explained that we're not all getting sick at once. One of my favorite science writers had put it this way, and I really liked it. There are now two groups of people in the world. There is one group of people who are actively fighting this disease, fighting this virus. They're looking for vaccine. They're looking for treatments. They are taking care of patients. They are taking care of other essential activities to keep things going. And then the other group is the rest of us. And our job is to buy them time. Buy them time to do their work, to make sure that everyone can receive the care that they need if they do get sick, to help protect those who are at high risk. That's our job. That's the rest of us. And we're doing that. It's not going to be easy, but we need to continue that, and we need to plan to continue that for a long time.
Okay, Professor Gallyot, are you in agreement? You have the same thoughts, or?
I am in agreement that there are groups of people, but the other thing that we need to remember is that we have put our healthcare workers in such a different arena than they were prepared for. The volume of students or graduates that I hear from who are really struggling mentally with this is difficult. They're going to work. They're frightened too. As nurses, as medical people, we've been exposed to all kinds of things, but the lack of some of the resources that they have, in addition to, they are not used to using Skype so that family members could say bye to their loved ones because they're not allowed in the hospital. They're holding hands of many people who are passing away, and in many cases, if you're talking about some of our long-term cares, they're losing people, and it is very difficult. It's mentally draining on our healthcare workers. And you could say, well, it's not just part of the job. The rate at which this is happening is difficult for them, and so trying to be supportive of them. When people are actually when the healthcare worker goes to a grocery store and gets, "Thank you for helping," that's a nice thing. Or people who are saying, "How dare you come here and spread that virus," it's really difficult. We're not ready. We are not ready to get close to people. Social distancing still has to happen. And we need to think about this one group that is really fighting that virus, but there's a fair amount of trauma that they're dealing with that we haven't begun to discuss yet.
I know we were talking a little bit before we started the recording here, and So I like this. I mean, the idea of the two groups working on the virus. And I want to get to some questions about the flu pandemic comparison and testing and why there are no drugs and those things. But I do want to ask, before we were talking, Professor Gallyot, you'd had this analogy, a weather-related analogy in terms of why we should still be social distancing and how. And Professor Finan was agreeing that it's going to take some time. That just because the numbers are looking better. Doesn't mean we get to, so can you make your analogy?
Absolutely.
Talk a little more about
I can absolutely do that. When people are looking at how to adapt to this, I don't even want to say new normal. When people are looking to adapt to this, most people feel like it's a blizzard. When you have a blizzard, you have to stay in, you kind of have to pull in, and there's a beginning and an end to a blizzard. This is a season. Much like if you want to get ready for winter, you know that it's going to last for a certain number of months. In Chicago, we have winter and construction, but I'm going to tell you that winter lasts for a certain period of time. Even when we get snow in April, we say, you know what? This is what winter is like. This isn't even a season. You need to think about this as a mini ice age. We're going to get highs and lows. So going back to life as we know it, not quite the same. And we need to think about that as people start to say, hey, things are going to get better. This is still a season that we have to go through. If you think about the flu, I'm going to give you a segue. If you think about the flu and other things, there's a season to that as well. Unfortunately,
this is my question, which is, I guess I wanted to ask it. Some people are saying we got to look at the 1918 flu and we have to make a comparison. And some people say, if I hear one more comparison to the flu, it's not the same thing. So is there some middle ground on that, or can we compare it to the flu, or is it a completely different animal? I'll let you both sort of take that one.
I think there are a lot of parallels with the 1919 flu. There are a great deal of parallels. But we are not dealing with the same virus, and we're not dealing with the same population that was exposed to that 1918 virus. The correlations as far as cities in the United States that maintained more distance, that were stricter about preventing large gatherings of people, their death rates were lower. And that's been borne out by studies. This is not the same virus, though. We don't yet know as much as we need to about how many other people will be infected by a single person who's carrying the virus. So there are statistical numbers about if one person has the virus and going about their normal activities, how many other people are they going to infect? And whether that is comparable from the 1918 flu, which was pretty high, to what we're dealing with now, it's not the same virus. It's not an influenza virus.
Okay. I'm sorry.
So the number of people who are getting the severe disease versus a milder form, we're also seeing differences from the 1918 flu in the sense that that influenza of that pandemic was especially hard on younger people who were healthy, previously healthy. And there are a number of reasons for that, but that doesn't seem to be the case here. It seems that younger people are less affected, more likely probably to have mild infections or to not show symptoms. And older people who have more pre-existing conditions, who have other conditions that kind of leave weaknesses in their immune system, they seem to be more at risk. We know that they're more at risk, and that is different from the 1918 flu.
Did I read, though, that 18 to 40-year-olds, 20 to 40-year-olds, what did I read about the stroke being part of this disease?
With younger folks, they might be developing high blood pressure, and high blood pressure, you don't have any symptoms. So all of a sudden, they might present with stroke-like symptoms. That seems to be an outlier for younger folks than what Professor Finan was talking about.
In terms of
with the flu of 1918 and 1919, people responded the same way that they're responding now, sociologically. They are tired of staying inside. There were riots about, we need to get out, we need to do this, we need to do that. And that reinfected a whole other group. And so we need to learn from that kind of history to say, you know, this is part of the human condition, that they're social animals. They want to be out. However, at this point, we should take our cues from history to say social distancing decreases the spread of that.
So, were you going to add anything else, Professor Finan?
No, go ahead.
No. Okay, so we're talking about this as being a global pandemic, and I guess I'm wondering, are we sharing research? Are we sharing techniques? Are we sharing things across the world, or seeing trends across the world that we can add to this discussion? And then, and if that gets into what about testing? Why isn't there a drug yet? Are we sharing research? Can you talk about all of those things?
Oh, wow. Gee.
Yeah. Yeah, well, absolutely. Researchers around the world are sharing information, and the internet has just made this ability to share information just amazing in terms of the collaborations that are possible that would not have even been possible 30 years ago. But there's close collaboration. The people who are experts, recognized experts in the field, they know the other experts around the world. They've met these people. They've had conferences with them. So the researchers have already had these networks of information exchange and collaboration. These have been set up for years. So I think all of this information is being shared. There may actually be, at this point, some oversharing. There are papers, publications that are in progress, but that have had findings that have been pre-released before they've been reviewed by experts in the field. I think there's a big temptation for researchers to want to find the answer, to want to find an answer, to want to be the first. Nobody's immune from that. Nobody is, so to speak, but nobody is entirely unaffected by those desires, and they can be very very noble and high-minded, but they get people, even researchers who've done research in the field for a while, sometimes they get overexcited. They want to share information, and the news media is on a constant cycle of content. And if these unsubstantiated claims or suggestions are out there, you can be pretty sure that a news organization is going to pick up on it and make their content.
How do you both stay with the substantiated data? And Professor Gallyot, you were going to add something?
I was going to add that there's an economic push to get the treatment for this as well. And so you're going to hear about some medications that have been tested on maybe 1,000 people, maybe 100 people. And, with our strict guidelines, that's nearly not enough. There are other medications that were not prescribed, but people had heard about. All of a sudden, there's runs on that to say, hey, maybe we'll take this. And they wound up getting heart arrhythmias. It wasn't a safe thing to do. There's a lot, as Professor Finan said, there's a lot of sharing. People want to try to help to control this. And believe it or not, we can. Some of the testing, even some of the testing kits, one day I'll have somebody test. I have family members not living with me. I have family members in other countries who've tested positive for coronavirus. They're hospitalized. They'll test them 2 days later. It'll come up negative, and they'll say, okay. A day after that, they'll test them again. It'll be positive. So guys, we still have to think about what are some of the better tests that give us those results. Testing is an issue as we kind of go through this, and symptomology. If for those who are symptomatic, we need to think about that. I'd like to asked Professor Finan what she thinks about antibodies. I'm sort of on the fence with antibodies to say, I don't know how accurate some of that is to say you have a natural immunity, because it's a viral component and it can mutate.
I think also we need to consider the question of the antibody tests themselves.
Mm-hmm.
The antibody tests, ideally, we want to have tests that detect everyone who has antibodies and that don't leave anybody out, but yet don't give us false results saying that people have antibodies that don't. And we should probably back up. When we're talking about antibodies, we are talking about a blood test that detects whether a person has had exposure to this coronavirus and their body's immune system has produced antibodies against it, antibodies being special proteins that target this coronavirus and to help defend that person against it. Antibodies are in many other types of illnesses like hepatitis. They're a good way to figure out who is now protected after having a hepatitis vaccine. We don't yet know if that's going to be the case, if antibody detection, if anybody's detected in a person who has recovered from the disease, is that a reliable test? We don't know that that means it's safe for them to go out. We don't know that it means people without antibodies are not able to go out.
So what is current testing?
Yeah, go ahead.
What is current testing actually telling us then?
Testing for the coronavirus or testing for antibodies?
Testing. So the testing, when we say, oh gosh, the numbers rose today, and we say, well, we did this many more tests. I mean, so what are testing numbers actually revealing to us? Or Professor Gallyot, you look like you want to...
I was about to say something. Sorry. What we did initially is there weren't enough tests available. So you see a big spike in numbers and people are kind of frightened that the virus is actually spreading. It's not necessarily spreading. It's that we're testing more people. And with testing more people, you're going to see spikes in the amount of the virus that's out there because we're actually studying it. If we weren't looking for it before, but people had it, we didn't know. But now, if you're exposed, we're trying to test more people. Therefore, you're going to get more positives.
But the test only reveals whether you've been exposed. It doesn't reveal antibodies. The current testing. Okay.
Well, there are two types of tests. There's the nasal swab test, which tests for the presence of the virus itself, saying that, yes, you're carrying the virus, you're infected with the virus, and the antibody test, which is a blood test. And the blood testing for the antibodies is not widespread. We don't have a great test for it that catches everyone and gives true positive and true negative results and doesn't let any false positive or false negatives fall through the cracks. We don't have a good enough test for that.
Is that because we don't? I'm sorry, go ahead.
The test that we really need more of is the nasal swab testing to look for the presence of the virus. And the numbers of people who are still testing positive compared to the total number of people who are tested at all is still way too high, which means there are a lot of people that we're not catching. And as Professor Gallyot was mentioning earlier, speaking about her family members, we're going to have to have enough tests because people are going to be tested repeatedly. It's not as though we can test everybody once and we'll be done with it. We'll have to be testing people repeatedly. And that's really the key to understanding where the virus is causing outbreaks, how to isolate people, how to find out who they've been in contact with to limit further spread. And testing, I think, is really going to be the key to making good decisions.
Do we not have an accurate test, and do we not have an accurate antiviral? Do we not have any medicine that works against this for a specific reason? Is it a host of? Is it because we don't understand the virus? Is it because there's too many people working on many different parts of it? Or so two questions. Why don't we have a good test, and why don't we have a good treatment, I guess?
When you're talking about testing, you're looking at specificity and sensitivity. Those are kind of tough words. Are we getting the results for what we're testing for? And how many false positive and some false negatives are there? That's part of the problem that we have with some of the tests that we're doing. Not all, but some. Therefore, you can say, well, is it safe? I'm going to say we're more safe than not, but we've also had to buy tests from different countries so that states can actually get enough testing done. We've not actually had some of the tests available to us. So there is some of that issue. Let's see here. You were talking about testing, and I'm sorry, Professor DuPage.
Testing, and why don't we have a good treatment? Why? So we've got what's quote unquote the holdup? And I mean, I have my own speculations, but I'm not in the medical field, so I'm just wondering if you guys can address that.
Professor Finan, you want to take that?
Or, are there any drugs or no good drugs, or,
There are some drugs. The one that we've been hearing about is remdesivir. That is a drug that was tested previously on other viral infections without great success. It's related to drugs that we do have that are effective drugs for other types of viral infections. But the testing of this antiviral drug is still in the early stages. It's showing some promise, but knowing everything that we do know about the virus, we know everything about its genetics, we know everything about how the virus proteins are built. We know very good details, but we don't understand enough about how it interacts with the human body and how it interacts with potential drugs. So there's a lot of guesswork that goes on, a lot of trial and error, and it's very frustrating. Nobody likes trial and error. They want trial and success.
Right.
But that's not the way it goes.
Okay. Did you want to add anything else, Professor Gallyot?
When there's trial and error, there are multiple factors that need to be taken into account too. If you're a younger person who is healthier without comorbidities might be some other potential complication, diabetes, cardiac disease, other issues. You might bounce back a little quicker, but you may have already had an immune system that can kick in. When we have other folks who have compromises such as diabetes, heart disease, or some immunocompromised condition, these medicines may or may not help. It may help, but there's a lot. It's not as easy as taking a medicine and having a cure, especially when you've got complications. Okay.
Oh, okay. Yeah, no, that's actually helpful. I guess I want to end with a couple of questions, or sort of myth debunking or confirming. But I guess I'd ask you both. One, I hope you're willing to come back as this evolves and we can have another conversation about it. But two, and then 3 and 4 and 5. I'm sort of wondering, there's a bunch of myths about how this started, or stories. They may not be myths, and there are a bunch of. I guess I'm wondering if you could debunk one thing and affirm one thing, what might those be? And for me, we have this whole story about the disease in Wuhan, and I guess I'm curious about what you might want to offer about how this started and where this started and what we know.
Well, I think the overwhelming evidence that we have so far is that this virus did originate in bats. There are many coronaviruses of different types that are found in bats. Most of them are not directly transmissible to humans, but with slight mutations, they could be. We know that bats do carry viruses, other viruses that have been transmitted to humans, and that have also made the leap from bat to human down to human, which is a big change. Not all of them do that, but it seems very likely, it seems the evidence is very, very strong that it was a bat virus. There are all kinds of situations in our world today where people are coming into contact with wild animals through moving into the animals' native habitats in search of more farmland, more places to build, more resources to gather. And as we encounter wild animals, we're also encountering their viruses. And so this is not unexpected. This is not out of the ordinary, really, for humans coming into contact with viruses that normally circulate only in animals. So it seems very clear that it was a bat originated virus that somehow mutated and was able to make the leap then, transmitting from person to person.
Okay.
Just to mention too, open air markets where you have live animals, and this happens throughout the world, where you have live animals and people. This is another way that things get transmitted, and I think that's going to change radically. You know,
Awesome.
having livestock where you can purchase them, and that happens throughout the world. So some of those processes will change as well.
Okay, so is there anything you'd like to affirm, debunk, or just add before we sign off? Either of you. Hello, dogs.
Speaking of wild animals.
Speaking of humans and animals.
And go ahead, Professor Finan.
No, I think I would just advise everyone to use your critical thinking when you are hearing news reports, when you watch, when you're flipping through social media. Have your skepticism turned on so that you can evaluate and say, well, you know, I'm not hearing from the experts on this, so I'm not going to pass it on to all my friends. This is not what the experts are saying right now. It's on me to not perpetuate rumors and conspiracy theories. That helps no one. And we all need to be, pulling together on this. It's going to take a lot of cooperation, and we all need to, I think, be responsible for trying to make sure that any information that we share is information that is backed up by science.
Okay, thank you. Professor Gallyot. Yeah.
I would definitely say we need to look at the experts. We need to understand the models. And while the news is a constant feed and looking for, sorry, I'm trying to wrestle my dog over talking here. Well, there's a constant feed of information. Some of that is sensationalized. And we, as what Professor Finan said, you need to have kind of a hypervigilance about that to say, wait a minute, what are the experts saying? And it's going to take a while as we get through this. It's not a blizzard, it's a season, and we can get through seasons, but there's going to be ups and downs for all of that. We do need to do this together. We need to keep each other safe. And I think out of this, we need to be gracious with ourselves and each other.
Thank you both. So I'm going to end with some takeaways: mask, wash hands, socially distance, and for the long haul. Yeah.
Don't touch your face.
or anyone's, right? Not even for the interrupting starfish joke. All right, ladies, thank you very much. This is great. And so again, I hope as this evolves, I can invite you back and we'll talk a little bit more about it.
Thank you so much for asking.
Yes, it's great to be with you both.